Let's do it. Welcome everybody to the obviously very formal webinar, but to this amazing Women in Trauma Surgery webinar today, where we will be discussing challenges in leadership. We have an amazing panel that spans an experience level. So no matter what level you are here, you are going to learn something amazing, I am sure. I'm very excited. And on the panel today, starting off with Dr. Krista Kaups, who is a professor of surgery at UCSF, Fresno. There she is. And Dr. Deb Stein, who is a professor of surgery at the University of Maryland. Followed by Dr. Kate Martin, who is a senior lecturer at the University of Melbourne, who deserves a special round of applause for being up many hours before the sun is up. And my name is Dr. Jamie Coleman, and I'm an associate professor of surgery here at the University of Louisville. We are going to start off. I'm going to share my screen. And it's just one slide. Don't worry. We are going to keep the organic nature of this conversation. But one quick slide. Does everyone see it? Yep. All right, perfect. I'm really kind of reviewing. Actually, you know, hearkening back a little bit to when I was asked to be on this panel, it was interesting. I was like, oh, am I a leader? Oh, should I be on this? Oh, I don't know. But it was great when the four of us really got together and started talking about how we wanted to address this topic and realizing that leadership really does happen in stages. And in fact, whether you have a title or not, just being a surgeon, you are automatically a leader. You're a leader in your operating room. You're a leader in the patient rooms. Your nurses, your staff, your residents are looking to you as a leader. You don't need a title. So I think when I first started thinking about this, it was kind of hearkening back to my first days of really being an attending. So regardless, before any title that I've been fortunate enough to have, I was really thinking about what my challenges were in the early days. And Kate, feel free to jump in as well on this. But for me, it was kind of these four different buckets. And the first one was kind of realizing people not knowing that you're actually in charge. You walk in the room, you walk in the trauma bay, and sometimes there were just times where it was difficult getting people's attention with either a lack of announcement going out that there's a new attending, with looking younger. Sometimes that happens, particularly I think for female surgeons, where people just assume you're not in charge. And I think for me, through that journey was really just kind of understanding that people are going to figure that out. That wasn't actually a crisis. In other words, I was in charge. I didn't need to prove it all the time, because at some point, people are going to start to read, people have EQ, people are going to start to read body language, people are going to start to realize the residents are turning to you, EMS will then start to report to you, the OR is going to start to look to you. And then you get into situations in which you automatically just become the natural leader. And so I think one of the things for me was really just respecting this idea that respect will come. And then I didn't need it necessarily on day one to still be the one in charge. Secondly, similar to after being invited to this panel, was feeling as if you don't know enough to be in charge. And I think part of it gets so hard, you know, there's always these curves about how, you know, as a junior resident, you start to feel like you know what you're doing. And then as you gain experience, you start to realize more and more that you don't really know what you're doing. And over time, learning to really realize how much experience you bring to the table, no matter what level you are. You have been through undergraduate, medical school, residency, fellowship. That comes with a whole host of experiences. And really on the inside, just doing that introspection and having that realization and valuation of the experience that I brought to the table. And I think the third thing, which really for me tied in a lot to the first thing, and that's one of the most common mistakes I think I see young leaders make, is feeling as if people don't know they're in charge, and then they're trying too hard to be in charge. And then it's kind of this, I say it's like a dog park. You know, all of a sudden everyone feels the need to make everyone else roll over and show their belly, and that, you know, dominance has to be asserted. And I think quiet confidence is one of those that you really need to learn the value of, because again, at the end of the day, if you know you're in charge, at some point that's going to come out. You don't need to necessarily shove it down people's throats, that you're in charge, that you're the boss, that you're the leader of the situation. And then lastly, I think one of the most important things was not really knowing how to be in charge. In other words, finding your own individual leadership style. I think one of the biggest things for me is realizing that people respond to authenticity. It's not necessarily the style in of itself. It's that people need to know that they're getting you, that you're not trying on someone else's leadership style. I was very fortunate to have been partners with Dr. Kleber Liu over the past 4 years, who I admire tremendously and I've learned so much from. But I use her as an example to particularly our female trainees in showing, you know, we have very different styles. So the style itself has to be right and feel right to you. Otherwise, that's when I feel like you're going to start getting into trouble with people feeling like you're being mean or rude. It's not so much necessarily tone, and we can talk about that too, but I think people just sense inauthenticity and they sense discomfort. And so that's, I think, what people are really responding to. So I think looking around you for inspiration and looking at styles and looking at how different people handle situations and pulling from those to create your own unique leadership style was something that I really had to learn and really work on in the first few years, particularly as an attending. Kate, what are your thoughts on some of those ideas?
Look, definitely, and I think I'll probably start with the last one first. And a lot of what I think we aim to be a role model, and I think that with that will then come that's part of leadership as well. And I think one of the nicest sort of compliments we can get as leaders, whether we're men or women or otherwise, is being a role model first. And I think if we start that early in our careers, right from that first day you walk in as a doctor, that very first day on the job, and that's where you start to develop that leadership style. I do, we look around us and we look at people and think, I like the way they do that. That's a really good way of handling that sticky situation. And then we also look at our colleagues at times. I think, that's not a good way of dealing with it. I think what comes in, you think, yes, note to self, don't do that. Don't do that.
Yes.
And we do, and that's how we form. And we probably then change a little bit as we go through our careers and the different types of roles that we have. But going then back to that first point too, it's not a title that we're given, and this is something I learned probably the hard way, I think, is that it's not a title, and those that are bestowed titles don't necessarily make good leaders. In fact, probably some of the worst leaders I've had to work with are those that, because they have a title, think that that's it. It's actually the way we act, it's the way we treat people, it's the way we listen to people or not listen to people in the negative. So I think that this focus on aiming for titles and aiming to work our way up the hierarchy is probably not the way to go about it. It's, as you said, being authentic, it's being true to yourself, developing your own style, being able to listen to people and treat people the way you want to be treated. And with that, you'll then start to get the best out of people. Introducing, one of the things I often do if I walk into the trauma bay and there's people I don't know, I just introduce myself. It's it's a bit easier when we've all got our name badges on, particularly in a resuscitation scenario. With COVID, we've all had to plaster our names and our position across our face shields. So that's made it actually quite easy because it's right front and center, and we all have our surgical caps now with our names and who we are. And I think little things like that have helped a lot too.
I think it's great. And I think you raise a really good point about every interaction with every leader is a learning opportunity.
Absolutely.
And whether it's a tone, whether it's body language, whether it's what not to do, but every interaction is a way to just add to that vocabulary within yourself as to how to be the most effective leader.
Can I just add one thing,
Absolutely.
Jamie, to tag off what Kay was saying? Because I think this is a really
Yeah.
good. The more times you have to tell people your title, the less the less important your title is likely to be. So I always introduce myself to people as Deb. Like I rarely even use my last name. I rarely even use doctor. With patients, I obviously do, but I just think that if you have to go in and be like, I'm the chief of X, Y, and Z, that's not the way to command the room. I think to Jamie's point about the way you command the room is by quiet respect and learned behavior.
I love that. I think at this point now, Dr. Kaups, if you want to introduce your slide as well with some talking points.
All right, that's great. And you know, that was already such a great start. As you can see, I'm having a little trouble with lighting here, so I'm trying not to be in silhouette, but I have a little bit of a rigged setup. So those were such excellent points already. You know, I almost feel like we could say, okay, guys, job done and let's move on. Are we able to share that slide up?
I can do it if you.
Yeah, I'm having a little bit of a technical.
No problem. I got it right now.
Perfect. Thanks, Jamie.
Is this your example
So-
of our great technology, Krista?
Yeah, pretty much. And just being adaptable with it.
But go with the flow.
Go with the flow, absolutely. You know, we've all
Very
had that
good.
happen. Your PowerPoint doesn't come up. And these are really, you know, we're not going to spend a lot of time going through that. And I was asked, and Deb and I'm Krista, were asked to talk about what happens if you're a little farther along. And you can get to a stage where you are so busy being busy that you forget what it is you're trying to accomplish. And that can really be frustrating. So, and Deb, please jump in at any time. But periodically, it's really good to stop and say, know what it is that you're trying to do. What are your priorities? What is it that you want to accomplish as a person? And what are your priorities in your interactions with other people? You also have to be honest enough to know yourself, know that what your particular strengths are, know your weaknesses. And we all have them. I mean, it's, you know, whether it's interpersonal skills, whether it's your tolerance for frustration. I know one of the things that makes me crazy is having to redo work that's already been done. If I've done a report or if I've done something and it poof vanishes, that makes me just bonkers. Or just be honest enough to recognize what's happening. Part of that too, and I think it's already been said, is but to be honest, be yourself, treat people fairly. It's easy enough. We all have people who we interact with more easily than others. And you have to recognize, you know, like, this is a person who does frustrate me, but I have to give them the benefit of the doubt. Recognize the strengths of others. If you've got a colleague or somebody who just loves administrative details and thrives on it, great. Let them make the call schedule, if that's what it is. Find your friends, find your allies, know your friends. And I think, as you can see from this discussion we're having already, is we've developed friendships, we've had the opportunity to form friendships. And your friends don't have to be at your institution. They may be people you meet at professional meetings. You have professional friends and I have personal friends, but I've got professional friends who are personal friends. And we talk about tough situations. We support each other. We advocate for each other. To go back to, I'm going to skip the listen to the whole story, but that basically means don't choose favorites without realizing that you need to get the whole story. And don't say yes to everything. I think I know that I have a, you know, what do we call it? FOMO? It's it's that, okay, if I don't say yes to this, what will happen? Hey, I'll never get asked again. And this is the importance of knowing where your priorities are and realizing. I mean, I was asked to serve on another hospital or chair another hospital committee last week, and I had to very honestly say, and it was somebody I knew, and I said, you know, actually right now I've got enough other things going on. Hey, here is somebody else on this committee who will do an excellent job running this. And thank you, but no thank you. And finally, I think we've already embodied, don't take yourself too seriously. I remember my dad, when I was a small child, always told me this. When I was a little girl, about 6 or 7, he'd be like, don't take yourself so seriously. It would frustrate me because I didn't know what he meant, but as I got to be an adult, I've seen all kinds of people whose parents evidently didn't tell them that. And so it's, hey, you gotta, we all trip, we all fall, we all spill our coffee. So realize that we are going to muck up and, forget the important speaker's name who you were introducing or whatever it is. And yeah, we're all surgeons. We've accomplished a great deal. But we've also had a lot of help. But guess what? We all still have things that we mess up, foul up, and that's what keeps it entertaining. Deb?
Yeah, first of all, I want to say that I'm jealous that you're an adult, because I still feel like, how is it possible to be this old and yet feel this like I'm not an adult? So I'm jealous that you think of yourself as an adult, because I still definitely do not. I think that the whole concept about don't say yes to everything, I think it's a really hard balance when you're first coming out of training and you're junior attending, between trying things out and like sampling the menu and not saying yes to everything. And that's a really hard balance to do. So the couple of things I like to kind of advise people on is, one is anything that does double duty is twice the value added, right? So if you're going to get involved in a project to do a talk for somebody that you can turn into a publishable review article, because you're going to do all this work to put together this talk, that's a win-win, right? So anything that you can do that does double duty for you is helpful. So for example, if you're going to put something together that's then going to serve as the basis of to write a grant, that's double duty, great. The other thing is to do things that bring you joy. I can't tell you how many things I've spent my time and energy doing that I dreaded doing. Stop doing things that you dread doing. Stop it. It's not worth it. Somebody else actually likes doing that stuff. And so I really think this concept of doing things that you truly enjoy and that bring you value, that bring value to you as a human being, I think are the most important things to be doing. We're all gonna, yes, nobody likes writing notes, nobody likes signing, whatever, right? Nobody likes that stuff. But as a general rule, spending a ton of time and energy doing things that don't make you feel fulfilled and happy just make you unhappy in your chosen profession. And if you're being forced to do it, you're probably in the wrong position.
Great wisdom.
I love it. So just to remind everyone, I'm going to keep an eye on the chat box. So if you have questions, please feel free to throw them in there. I meant to mention that at the start of the session. But, one question that we'd kind of tossed around before that I think is definitely on the forefront of a lot of people's minds. You are hearing complaints from the OR staff and nurses that one of your new junior female faculty is impatient and, let's say, the word bitchy in the OR. How do you approach this issue?
You know, toss that out to one of us, Jamie?
Yeah, Deb, why don't you?
Since you spoke up. Yeah, so this actually just happened to me a couple of weeks ago. So one of my male junior faculty came to me and he was like, listen, he's like, she's great, she's wonderful, but the OR staff's complaining. And I don't want her to, he was very concerned that he didn't want her to get a bad reputation. He actually came to me saying, how can I tell her? I said, well, why don't you not? Right? Because but let me. It's a hard conversation to have with people. And I think that one of the things that I always try to do is I always try to relate. So I tell the story. I don't know if anybody who's on here was a resident with me, but I was a total bitch when I was a resident. I was a complete bitch, to the point where I went back. My sister had surgery at the hospital where I trained, and I went back and I went up to the resident room. It was like 5 or 6 years later, and there were pictures up on the thing, and my face was scratched out. Like the junior resident just scratched out my face.
That's impressive.
Right? I was like, ooh. So first of all is relatability. Like, listen, I've been there. And then so one thing is making sure that the individual can, first of all, recognize that they're doing it. And this individual, who, as I was speaking to her, definitely recognized it and definitely was like, help me with this, that you're right. This was a problem. I got, she's junior. She was worried about the case going well, and so then one is relating, 2 is making sure that they understand that there's an issue. And 3 is then giving them some tangible ways to solve it. So tangible things that you can do. For example, for me, up until 3 years ago when I quit smoking. I'd be like, "Can you just have a cigarette now?" Right? I can't do that anymore. So, but tangible things that individuals can do to get themselves out of that in real time. Sorry, go ahead, Jimmy.
Well, I was going to say, I mean, I think, one of the, Dr. Davis gives such an amazing talk on physicians that have been difficult or are viewed as difficult. And it's such a great talk. It's one of my favorite talks. But the thing is that, came through to me on that was, again, like, a lot of that comes from, something. And I think for this, particularly for young attendings, it's coming from a place of discomfort. And I think raising that from the subconscious to the conscious, so that when you are uncomfortable, recognizing that you're uncomfortable, so then you place that filter between what you say and what you do, so that you recognize that you're uncomfortable, and hopefully then it prevents that discomfort from coming out in your words and behavior to other people that you don't necessarily mean for it to. And that can be frustration. Discomfort doesn't have to necessarily mean insecurity, but it can be frustration, tired, and sometimes it's just like you said, it's taking a pause within yourself. Maybe the OR needs a pause and say, hey, sounds like, seems like we don't have the instruments that we need, or something's not really going well. Let's all take a moment. Let's refocus. How can I help? And really try to put yourself back in the driver's seat of that situation.
I also think that one of the things is that it's going to happen to us all, right? We all lose our temper. Going back and apologizing is also, don't never underestimate how far that goes, particularly with our colleagues, particularly with nursing staff who they're just trying to help too. They're not perfect either, right? I really think that recognizing that like, oh, damn, I behaved badly. Let me go back and really just give an honest apology that I didn't mean to behave that way, really goes a long way. Go ahead, Krista.
Oh, no, I'm sorry. I thought you were finished. Sorry.
Nope.
Okay. No, what I was going to say, and Karen Browse put a comment in the chat too, is getting the whole story.
Right.
Was this just one episode? Is this ongoing? And talking to that faculty member who, she sounds like they've got insight. They're uncomfortable with what's happening. So is it a lack of supplies? Is it a particular episode? I mean, my general OR persona is that I'm not a yeller in the OR, but every once in a while I'll use what I call my loud surgeon voice if I think people aren't paying attention, or the blood is welling up. No, the blood's shooting forth and we're ankle deep and things are going poorly. I will use my loud surgeon voice and make sure I've got everybody on the same page. But every once in a while you do have to yell at somebody if they're not paying attention or whatever it is. And I agree completely. It's the importance of also going back and saying, hey, I am sorry. Or we've all had the situation where it was whatever straw that broke your back and you just lose it. And it is so important to be able to acknowledge that your behavior was not appropriate. And, assuming you're not wildly out of control and raging and throwing sharp instruments, people will forgive you because they know that that's not your normal behavior, how you treat people.
And I think, I was just going to add this question really quickly because I think it pulls well into this. Yes.
Yeah,
Dr. Barry's question. How do you pull out the bias versus the truth in these scenarios? Because we all know that this is part of the conversation.
But I'll actually tell you what I think is that I don't think it matters because perception
That's
is
what I was going to say.
And that's problematic for us as women, particularly for us as women surgeons, because we are very quick to be called a bitch, right? The one time Krista uses her OR voice, right? So it's about the rest of your persona, right? How you treat people, to Krista's point about being kind to people, being generous of spirit, generous with your words. And that way, those moments where you do have to exert your authority, people know you're exerting your authority, and that's not that you're not a different person. But I do think that perception is reality. And so we have to work a little harder, right? That's just the kind of the nature of what it is. And to everything that Jamie said in the beginning, as long as if you earn people's respect, then you have to work less hard on the back end.
And that's what I was going to say too. I think we have to separate out a faculty member, a faculty member getting in trouble for this versus a conversation, in the sense of, yes, that's to me where bias comes in. That's to me where, do you really truly have a problem with that faculty member who's being completely unprofessional over and over again? Or is there an element of bias? That to me is unlinked from the scenario of where you have OR staff who view a female surgeon as difficult. And there's
let's let Kate
Oh, go
jump
ahead.
in as well.
Please.
She's been
Yeah,
patiently
not a
having her
problem.
hand up.
Oh, that's all right. No, it's hard when there's so many.
Oh
people
gosh,
on
I'm
the
so
screen.
sorry. No, it's,
No, don't.
I need to
No
change my
stress,
view.
Jamie. No stress, Jamie. No, and I think that's a really important point. I think this is one of the aspects of leadership as well. And I think as a general rule, we do it pretty well as women. Not that I want to bring the gender thing, but I think it is a skill we have, is that it's just getting the full story and listening to people. Well, what is it about that behavior? Not only does it make the group or the person complaining reflect on what it is, and then maybe reflect on some of their own biases. Because, for example, not to look at, it was a difficult situation. There was a lot of bleeding. So, well, do you think maybe stress was part of it? Because then when you do have that conversation with that individual, you can at least, you're showing that you've listened to two sides of the story, and you've got a little bit more sort of a feel of the circumstance in which it happened as well. I think it's also very different when is this one person complaining versus a group? And I think that makes a really big difference. And I think getting a bit more collateral information is always really good. I think it's a bad thing to go in and have a conversation with someone based on one person's sort of feedback. I think you need a bit more just to get a feel for it, because there's always three sides to the story. There's his, hers, and then the truth somewhere in between. That's been my experience anyway.
100%. Any other comments, Dr. Kaups, on that?
Not
comment?
at all. I think
Dr. Davis, do you want to hop in on this?
I was going to propose going, because I know you're watching time. I think we've got lots to talk about. So
We do.
I was just going to say, as a former disruptive physician,
As a reformed disruptive physician.
reformed, deformed, I don't know. In any event, we do have a fine line to walk when we're trying to maintain control of a difficult situation. You don't want to be perceived as being a disruptive individual. And it's a more difficult line simply because there are implicit bias that take things that are normally viewed as effective leadership skills in men and are viewed as non-effective in women or detrimental in women. So I think we need to understand that, but I don't think that we should let it stand in the way of getting our job done, particularly when the patient is at risk. So, but anybody who wants to talk about how not to be a disruptive physician, I've got 20 years of experience in metamorphosis.
I love it. All right, moving on to an additional question. All right, I love this one too. Help, I'm overcommitted and now everyone's unhappy. My colleagues, my family, my boss, and myself. What do I do? And I think this is great because this ties in well, Deb, with a lot of advice we give for early faculty or early career surgeons, where we're like, try on the shoes, see if they fit, walk around in them, but then at some point you get into a situation where maybe you've tried on too many things. Dr. Kaups, do you have any advice on this one?
I'm watching the chat too, and Dr. Brazel has an excellent thing that says no.
It's amazing.
Is a complete sentence. So I do think it's, as I mentioned, is having an idea of what your priorities are, and I'm the last person who's been very deliberate. I'm always impressed with the people who are like, well, I want to do this, and then I will be, the empress of the universe. And you're like, wow, that's amazing. And I've been very, very fortunate that I've had a number of great opportunities. And I think it is being deliberate to say, exactly as Deb said, look at the things that bring you joy. Where are your gifts? Where are your things that you really love? And depending on what it is, to say, but suggesting somebody else. I mean, this is 10 or 15 years ago. I was asked to be a representative to the local, I can't remember what committee it was, but it was something that was like really not my interest at all. But I said, I've got this colleague who really likes this. And how about if you talk to Dr. So-and-so? Dr. So-and-so happily took it on and everybody was happy. But so have an idea of, and also have a good picture of what it is that you've said yes to, like keep a list. And look at that. And it really is important. I'm not a great example, but is making sure there's time for yourself, for your loves, for your things. Because I have certainly been in it's work, 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 work all the time. So
I want to highlight two things actually. One is Dr. Cow says in the chat box here, her friend has a drop-down menu of ways to politely say no. I think that needs to be a share.
Yeah, Lily, you got to share that, please.
I need that. Please send. And secondly, I have to just comment on Dr. Bulger's comment in the chat box, because one of my favorite techniques just in life is outsourcing. But as a way to look to someone, exactly what you're saying, Dr. Kaups, but in a way that you can stay involved in the project. Look to have someone who can become involved. As Dr. Bulger states, perhaps you can mentor someone to get a project done, which is a win-win. So you're not necessarily saying no, you are actually saying yes for the opportunity, but you're sharing that opportunity with someone else.
That is an excellent suggestion.
Yeah, I'll just say one thing about mentoring people is you have to be a little bit careful, because mentorship takes a lot of time and energy also. So it's perfect for a discrete project, a book chapter, something. But if you're really going to say, I'm going to take on this research project, you're like, oh, now I don't have time for it, let me mentor somebody through it who's never done it before. That almost takes more time and energy. So I think you just want to be careful with that balance. Yes. I think also once you're already overcommitted, I think that the first most important thing is being honest with yourself about it, right? Because there's nothing, if there's one thing worse than not getting things done, it's doing them poorly. And so the earlier you can acknowledge that you just can't do it all, and it's a little disingenuous to have Eileen, Bulger, Kim Davis, and Krista Kaups to have this conversation with, because they clearly always do it all and make the rest of us feel like failures when we can't. But that being said, I do believe that it's important to acknowledge that you don't want to do a bad job at something. And so going back and saying, I know I said I could do this, but let me help you find somebody else who has the bandwidth. I just don't have the bandwidth right now. I think is really important to acknowledge it, because making yourself unhappy trying to do it all is just a waste of time.
And the other mantra that I've also learned in the last few years, I don't know if we did a show of hands about who feels like they're fairly much a perfectionist. I think it'd be a pretty good show of hands. Yeah. Just consider the source, consider the audience.
Just one more thing we failed at. That's all.
No, done is better than perfect. And sometimes that stops you from getting started, as you're like, I have to write the perfect book chapter. You do want to do good work. I'm not saying do lousy work, but you're not necessarily going to win a Nobel Prize for your book chapter, even if it's the most amazing thing in the world. So sometimes it's better just to get it done well, not perfect, and get it done.
Can I jump in on that, this conversation too? I think it comes back to what also makes a great leader. And that is one of the things I've got is you always want to make yourself redundant at the end of the day, so that you've got a team around you who are actually quite capable. And there is nothing worse than being micromanaged. And there, I think, is nothing worse than having to micromanage, particularly a large team. So I think it is, and that's sharing those responsibilities. And if you're asked to do something and you think, look, this is something I have an interest in, but I just do not have the time to do it, to give it justice at the moment. But I know someone who would really relish this opportunity, and having that team around you and being able to facilitate others, it's the same goal is achieved at the end of the day. It can be actually quite rewarding. And it's I quite like to use that line, my aim is to make myself redundant. And sometimes people, particularly the really young junior attendings, will look at you a bit weird and say, but that's, you look at the great leaders, not just in medicine, but across many sort of professions. And they kind of just sit there quietly, but they've got a team around them that they help facilitate and get the best out of. So I'm definitely a fan for sharing the load, sharing the love.
Dr. Davis highlights, I think, a key point here, which is transparency. And what she says in the chat box is get it done on time as much as possible. But when you realize that you're oversubscribed, prioritize what needs to be done, ask for forgiveness, also known as an extension. But I think it's true, being transparent with people, whether it's you need to say no to an entire project, whether it's that you're running late, whichever part of it, I think it's a key value that I think pretty much a lot of people really look for in leadership. All right, next question for this amazing panel. What advice do you give to a young leader who is struggling with confidence problems? How does someone gain confidence? This is a little bit of imposter syndrome, could be a little bit too of just clinical experience or experience in a role. Maybe they're early in their career, they feel early in their career when they gain a new leadership position. What do you all suggest for this?
I'd say part of it, and it depends whether this is more of a clinical or a, administrative leadership director kind of a thing. Some of it comes, how you think about how you develop confidence. There are some people who are born naturally confident. Sometimes there's the fake it till you make it kind of thing. Like, I think we've all had situations where we tried to look much more confident than we felt. But there's also that, hey, I know you've got this. I can remember having phone calls in the middle of the night when I was on backup call with some of my younger colleagues, years ago, and having somebody call and say, hey, this is what I've got. This is what it looks like. This is what I'm doing. And you're saying, great, you've got this. This is perfect. Do you want me to come in? No. I said, but feel free to call me and I'll be there. Or there's other times you come in and you're looking over somebody's shoulder going, hey, you've got this. I know you're doing a great job. It's perfect. Or sometimes saying, I don't have anything else to add. You're doing the best job you can.
Dr. Stein?
Yeah, I was going to say the first thing is telling whoever that is, listen, we've all felt that way, right? So first of all is normalizing it, making sure they don't feel like they're an outlier. I remember the first time I realized that imposter syndrome was not just me. I was floored by that. I was 100% convinced it was just me. And I was already attending at this point, I think, before I realized that this was a real thing that women in particular, but many of our male colleagues feel as well. So I think the first thing is normalizing it for people. Yeah. The second thing is exactly as Krista said, is being whether, hey, do you want to run through it? Call me in real time. Do you want to post, do a little post hoc analysis of what happened and how you did and what your thought process was. Those types of just being there to support that individual, whether it's with clinical decision making, do you want to try this out with me? I can't underestimate how important that is to people, to have somebody that they trust, who they trust is going to be honest with them, but is also going to be kind to them, to run those types of things by. I think that is probably, in my position now, what I feel is probably the most important job the most important role I can fulfill for my junior and mid-level faculty.
I think for me, some of it too is just introspection, just really sitting in yourself for a minute and realizing everything that you've done. And maybe you need a list of it. Maybe you need, a list of accomplishments. Maybe you need something tangible that's, on your refrigerator, on your mirror in the morning, just something tangible, because you've done a lot. And sometimes it's easy to forget how much you've done.
So to that point, Jamie, I could not agree with you more. I think that we are so good at focusing on the negative. If you think about it, every test you've ever taken, you've walked out of focusing on the 10 questions you didn't know the answer to. You completely forgot about the 90 you breezed right through that you did it without a thought, right? Yep. And we all do that in our lives. So I think, to your point, stopping and recognizing your successes, write them down, right? I mean, look what you did accomplish. I'm sorry that one manuscript got rejected, but look at the 5 that got accepted. And really consciously focusing on the positives and on the wins that you already achieved, because you already have done so much.
I do want to highlight an amazing question, Dr. Buchan. Hopefully I'm pronouncing that correctly. How do you distinguish between being confident? And then again, I think this pulls into perception, right? Being considered as arrogant or proud.
I'd invite Dr. Martin to, without putting you on the spot, Kate, I can see you smiling over there.
There's a song by a 1970s band. Some of you may have heard of, Skyhawks, called "Ego is Not a Dirty Word." I'd actually suggest it used in the wrong. It's fine maybe on the sporting field. I'm not too sure in the clinical setting. I think it can be hard, and I think this comes back to just being honest. I think it does ego. We call it ego here in Australia. I remember when I first started, I was very junior. It was my first year as an attending, and I was sat down by a senior colleague who said, you have your FRACS now. You can do all of these things. You have the ability. And I said, look, no, I'm still some things I do absolutely very well. Other things I do need to call for help. And I think coming back to that area, that point of asking for help and sharing that cognitive load. Again, we share the love. And that's one of the things that attracted me to trauma surgery in the first place, was that trauma is very multidisciplinary. It's pretty rare you're there on your own, really on your own. And you shouldn't be on your own, I think, particularly in major sort of centres. And so I think, it's, whilst we can be confident, I think it's the way, it's all in the mannerisms and the way that we come across. And and I think one of our roles too as leaders is to try to calm the room. It's okay, guys, this is where we're at. We're going to go through this, and this is my plan. Sharing your thoughts, being open with your thoughts. This is what I think we should do, and this is the reason why. Feel free to butt in, everyone, if you've got something you think can add to the situation. And I think that diffuses it, and it shows that you're sharing that cognitive load with everybody, but you're happy to make the call. You're happy to take the responsibility. Another term I often have for myself, and I say, okay, time to put my big girl pants on now. And that's something I use just to calm myself down. Also, usually lets the people around me know, okay, she's a little bit stressed. Okay, just take the time to put your big girl pants on and you'll be fine. So I guess I think, to answer the question, how do you distinguish between it? It's the way we come across. It's all in the delivery of it, I think. If you bowl on in there and say, oh, this is what we're doing, it's not going to work too well.
And I think what's highlighted well in the chat box too by Deb, the difference between arrogance and confidence is kindness. And I'll tag on to that confidence is quiet. Arrogance is loud. And then, I was gonna say 80% of, communication is nonverbal. So some of it's just, I think, like you said, Kate, recentering yourself. Saying, okay, it's time for this. I'm going to take a minute and here's what we're going to do. Deb.
Yeah, I think what I was trying to say was exactly what Kate said, which is that it's not just about the how I feel or how I feel about a given situation. It's how I interact in that moment is the difference between when I talk about being kind. If I'm as opposed to being arrogant, I'm being confident. There's two very different ways of living in the moment. The other two things I try really hard to do, to be being completely intellectually honest. Number one is I always take responsibility, even if it wasn't me, right? It's ultimately our responsibility as the attending, as the boss, as the one in charge, irrespective of who actually was holding the needle or the knife or the whatever. The other thing is I try to be the first one to admit my errors and to be introspective about them and be publicly introspective about them, to debrief and freely say, I should have done something differently there. I think that's really helpful in differentiating between a good clinical decision maker and an arrogant one.
Couple questions, they're rolling in now. Linda asks, I'm a junior strong female in surgery with a loud personality. Have you experienced male surgeons accusing you of being difficult or bitchy when you act as a leader compared to if a male said the same words or took the same actions?
Nah, never happened in the history of the world.
I'm actually going to go to Dr. Davis on this one because you alluded to this. No, but you alluded to this earlier. I have a reason for it, I promise. You alluded to this earlier, though, where you talk about traits that are admirable or viewed in a positive light from male leaders that aren't necessarily always, they don't translate well over gender. Would you want to comment or expound a little bit more on that? Because I think that's what the question is really aiming for.
Yeah, I think there are implicit biases. And as I mentioned before, it's very difficult to deliver the same message in the same language that a man would deliver it in an operating room, either to a male or another female colleague. And I will say that there have been times when I found that the men are more willing to excuse or ignore, and our female colleagues take things more harshly. So I do think that we need to be cognizant of that. And, you know, one of the ways to address it is if you think that you're appropriate in the moment, take a moment afterwards to debrief, have a conversation with that individual, really kind of just clear the air and be transparent about the ways in why you said and did what you did. But also don't be afraid to take feedback. I mean, I joke about it now, but one of the hardest things for me in my career was learning how not to be disruptive. And I thank the many individuals who have helped me address my behaviors and help me to be more, less bitchy, shall we say, over time. So I think that is, take the feedback. If you believe it, work towards changing it. If you don't believe it, then have a dialogue about it. But it is harder to be a woman in surgery than it is to be a man in surgery. I firmly believe that. The other comment that I'll make is I want to highlight something that Eileen brought up earlier in the chat, and that Rachel is mentioning now. Never be afraid to call for help. I'm a PGY 31 now. I was doing a trach. I couldn't find the trachea. I called for an ENT colleague. Don't ask. Couldn't find it.
You can't find the trachea.
Don't even start with me. I know where it's supposed to be.
Where what? I just out of curiosity, where was
No,
it?
where was it?
It was off
The
the right.
arm.
But call for help. Don't be embarrassed. If you can't, even as full professors, I call for help, not infrequently. I mean, not every day, but don't be afraid to ask for help. And if you are a junior faculty member and you want to run something by one of your senior faculty members, do it. Even if they're not on call them and say, hey, I'm really sorry to bother you. Can I run something by you? Right? Because it's that level of dialogue that's going to help you to provide the safest patient care.
Yeah.
And now I'm going to be quiet again because I said I wasn't going to talk.
Oh yeah, that's right.
It's my fault.
Hey, that's all right. But for the good of the patient, it's exactly. I mean, maybe, and there was a comment or a question that went by as, to deal with imposter syndrome. But remember, we're focused in the OR or in the trauma base. We're trying to do this to provide excellent patient care for the good of the patient. And if that's going to get the right care, the best care, let's call in a colleague.
And Rachel, I'll say too, I think when you're talking about the voice in the back of your head, bring it again from your subconscious to your conscious, make it a teaching point for your residents during the case. Again, it's calling out what you're doing, and that's confidence. That's saying, hey, listen, this is why I'm calling. And actually, I want to make sure that you guys all know this is a learning point for you all too. If you're not sure, you call. And Eileen, I think you had a comment too.
I was just going to, I think this is so critical. And I think this as leaders is our job to ensure that that's the culture. Every time we review a bad outcome at M&M, every time we say, gee, maybe you should call in somebody next time. I mean, we make it the culture that, if you have a difficult case and you're a young attending, we expect you to call for help. We expect that you're going to have somebody come in and take a look, to give you a second opinion on the phone, whatever it is, we expect that. And I think you want to work in a place that has that culture, but B, you want to create that culture. I think as you're coming up as a leader, I think that's our job to make it so that the residents would view that as a strength and not a weakness.
And not just to have our junior faculty do it, but do it ourselves as leaders.
Yes.
To Kim's point, right? To call somebody when you can't find the trachea. Well, that sucks. Let me call somebody to help give me a hand. I think to not only insist on that in M&M, but also to model it day to day.
Modeling it.
And that's the
I think that's a great
between-
point, though. It's the more is that we become leaders. I mean, I don't know if you guys are aware of this or not, but right now you have the chair of the COT, you have the president-elect of AAST, you have the chair of the Trauma Burn Surgical Critical Care Board, you have member of Trauma
president of
Surgical
EAST.
Critical Care Board, president of EAST, you have Kim Davis, who's treasurer, AAST. You got some badass women in charge, ladies. Take advantage.
And not to mention the people who are, who I see represented on the screens as well.
Right?
That's
Where's
true.
Karen Brazel?
She's
I
there.
say, and Lillian made a point.
Lillian and.
Lillian made a
I'm sorry, I
point
don't want to call
too.
out anybody. I don't mean to be calling out people by name. We're all, but recognizing that this is normal now, right? Your leaders are going to be women. And so a lot of this stuff that we're talking about now, yeah, we're gonna have to muddle through it for a little bit longer.
Yep.
That should all ultimately start going away. It already is compared to when, I mean, I can tell you from when for the old folks in the room compared to when we were kids. This
And I
has already
think-
got better.
And I think that that's, some places too, there are ways that you can implement that. I think bringing it up, modeling it for sure, bringing it up at M&M. And at one of the places I worked, it was a rule that if you had a patient that was going to die on the table, they were not going to die on the table with either a second attending not being called. Even if you just ran the case over, with the attending in the head, if you were really worried about losing somebody, and it just made it part of the system and part of the culture that I think Dr. Bulger is alluding to.
I think the other question we really should address probably in the chat before we finish up is the one about, having an argument with a male attending.
Yes, it's our next one.
You're right. So I would love to hear the group's thoughts on this. I think the issue of microaggressions is still a real problem. And it does relate to the gender schema. And we've talked a lot about how we've sort of had to adapt our style in order to navigate, I think, gender schemas. And hopefully over time that will change. But I would love to hear the panel just speak to that issue a little bit.
So for the full question, in case someone hasn't seen it, but I want to paint a scenario in which yourself and a male attending seem to have an argument about a particular case. You seem pretty confident about your method, but it eventually goes all wrong and you get sexist comments about it. So basically how to handle being wrong as a leader or after a tough interaction like this. Dr. Martin, you want to start us off?
Yeah, why not? I think this is tough, I think, particularly with regards to the microaggression aspect of it. So just to with that particular scenario, I think the first thing is just to be honest and to say, well, look, you were actually right. Thank that person for what help they did give, because it's pretty rare that they were completely useless and of no help at all. And acknowledging that. I think that when any sexist remarks are made, no matter what the scenario or the setting in which they're made, is you need to call them out. And it is hard. I will warn people that there are some people that really don't take too kindly to that and can react as predicted and can make life very difficult. But I think that's probably one of our biggest challenges as women in surgery, is that we still need to continue to call out the bad behaviour. I think you need to do it respectfully, you do it privately, you don't do it in front of everybody. But you do need to, if someone is being sexist and making remarks that are based on something other than what was happening at the time, you just need to call them out for it. Start with a positive. And am I allowed to swear on this? We call it a shit sandwich here in Australia, where you, something nice,
We
give
do
them
in
the
the
bad
US
feedback.
too, Kate.
It's the same.
Follow it up. Yeah. So, but
It
I
sets
think
the
it is-
ocean.
it does. And acknowledging that once you do that, it's going to be tough between you and that person potentially for a period of time, but it is the right thing to do. And I've called out bad behavior before with people who I used to respect, and their reaction has meant that I probably don't respect. Well, I don't respect them as much anymore. But at least I always think I made the right call in calling out the bad behavior and calling it sexist and misogynist and everything for what it was. So it is still tough, but I think as a group, and now that it is part of the narrative, we actually do, we have a right to call it out. And we also, I think it's part of our duty to make it, to pave the way for the women that will follow after us, to make it just that little bit easier if we can.
I 100% agree. And I have a similar approach where, I always kind of start out, let people cool off and then go back and just, start with, hey, we're on the same team. We both thought we were arguing for what was best for the patient. And then I think secondly, to just mirror points that have been made throughout is, I think we both maybe didn't handle that conversation the best. here's what I'm sorry for my contribution. And I try to open the door to let them come up with it. And then if they don't, then, after you've already admitted your role, even if it was small, just empathize with the situation, but then say, this really impacted me the way that you said it. And, just talking about it. But I think we have to address it. It's not going to get better if we don't.
And if you don't call it out, you'll be sorry that it'll be something that you keep in mind, and you're like, I never called them on that. I let it go. And you're not giving them the opportunity, as Eileen's saying, you're not giving them the opportunity to improve their behavior, to be aware of what they're doing, because they may not be aware, or they may need to be put on notice that they can't do that.
I agree. I think Nicole wanted to comment.
Go for it. I apologize. It's the way I'm seeing that.
I have to figure out the whole unmuting thing because it's not a Zoom meeting if someone doesn't talk muted. But I think the other thing at that core is, especially for that person that doesn't realize it, that can set up a sort of a misunderstanding that can last years. To be transparent, it happened between myself and one of my partners. He said a flippant comment that he didn't even realize cut me to the core and affected our relationship for about 8 years, until it's like, something seems different. I'm like, well, do you remember that one day where you said only, really smart, famous people end up being the president of East? Why are they picking you? You remember that comment? Yeah, that one killed me. Yeah. So, and he said it in jest, but it didn't feel jest-like to me. So, it happens to all of us.
Well, it definitely happens to all of us. I will say I'm very torn about this issue, because I get a little sick of always having to be the grown-up, right? Like, why does it have to be, you insulted me, I have to go tell you? Like, now why is this on me to fix your problem? But your points are all very well taken, that if you don't call it out, it doesn't change. That being said, the environment I've been in, I've been very, very fortunate to work for a number of individuals who really don't tolerate that. It's just not in the culture. So I freely admit that I may be living in a different world than other people, but I typically have fought it more in the moment with I've tried to fight it more with humor. Although I totally agree that is completely the grown-up way to handle this, is to have a conversation when everybody's cooled off a little bit. I also think that there are some things in the moment that you don't, what the last thing in the world you want is for this to lead to long-standing resentment among two partners, to Nicole's point. I mean, that's terrible. That's horrible. And if you don't say something, then that is on us. If we're insulted and we don't call it out. But I freely admit I tend to grit my teeth when I have to do it.
There's an excellent comment, because we are running out of time,
Yes.
but there's a great comment from Kate that says the behavior you walk past is the behavior you accept. And there's a great question from Morgan Schellenberg, who says, okay, what if it isn't a man? What if it's all the sexism, macroaggressions are coming from other women?
I actually go the same route. I actually had this happen a year or so ago, and I sat down with her and I said, and I just brought up, I said, particularly, coming from another woman, this felt even worse, but I treat it the same, quite frankly. I think it's about relationships and bridging and making those, and then it becomes less about one comment. It's one comment in a story. It's one comment in a bigger picture, but I personally address them the same. Dr. Stein.
And this kind of goes to what I was just saying, is I tend to be somewhat uncomfortable with this conversation. So I just want to freely admit that. Is I also think that sometimes we get a little hypersensitive as well. And I'm not trying to underestimate that this is an actual issue and an actual problem. But one comment said that's clearly said in jest or in humor. We don't need to take offense to everything. So it's a balance, to fine line, and I'm not suggesting that if you are truly spoken to in a way in which it suggests that you are in some way inferior by the nature of your gender, that is not problematic. But I also think that we're all really sensitive to this right now, and sometimes, especially when it's the heat of difficult clinical situations or difficult work environments that we all can take a little bit of a deep breath sometimes. So I'll just throw that out there.
I think it's great. And we're actually out of time. This was fantastic. I know we could all do like probably another hour at least on this.
But we got through 3 questions, Jamie. That was
We
pretty good.
did.
were
We got
excited.
through 3. It's good. We had a long list that I knew we weren't going to get all through, but I think it's another good point, another idea for another webinar is a second part of this. But thank you all so much for joining today. I really appreciate it. If you're not yet a member of WITS, you can do that through www.aast.org. So
It doesn't cost anything. It sounds like
It's
you're selling
free.
something, Jamie.
No
I
membership.
know,
no
I'm going to say it.
application.
It is free to sign up. And if you're not a member yet, please consider joining. That way you get on the list. So
And it's not
you
just
are
a free
aware of all the
trial. Like
webinars.
you don't get charged like after 6 weeks or 6
No.
months.
It's not a free now. And then you have to put in your credit card number, even though we say it's free. No credit card number.
And,
Your
and no
name and email.
requirements.
But everybody
Yes.
is welcome. Please come join.
And if you have any suggestions for future webinars, Eileen and I have mapped them out for probably the next couple of weeks to months. But if there's a topic that y'all think is really important, email me, email Eileen. We can certainly juggle the schedule if you think it's of importance, something you want to hear, concerns that you have, etc.